we've got two talks here this afternoon and then another Q&A session. So the first speaker is Evan Yu, who's a medical oncologist here at UW Fred Hutch in the SCCA. And Evan has had a very strong interest in the use of imaging, of very advanced imaging technologies. And there really have been major advances just in the last 5 years of using MRI and PET scans and others. So he'll give us an update on imaging. Evan?
Thanks so much, Pete, and thanks for you all being here today. I apologize for my attire. I just came from Bladder Cancer Advocacy Network. There was a fundraising walk today, and of course, Dr. Montgomery went home and showered and changed, but I came straight here. But the main reason was to do the opposite of Dr. Nelson. Dr. Nelson, if you know him, tends to dress down, and I tend to dress up a little bit more. So we decided to go opposite today. He put on a suit and tie. I went in t-shirt and baseball cap. So I'm going to talk about imaging in prostate cancer, and there have been a lot of exciting changes in this field recently. But I'm going to start off with some introductory slides to ask the question is, why do we image people? Why do we image? Well, first off is sometimes we can find the cancer. I mean, it's a screening technique that's been used in many different cancers. It's not a validated screening technique in prostate cancer because we have other good screening modalities like PSA, but it is a potential screening tool. It can help make the diagnosis, and it's also important for initial staging. And what initial staging is when you are found to have the cancer, and this is true for just about every type of cancer, you want to know how extensive the disease is. Is it localized to the original organ, or has it spread outside of the organ? And then once you've undergone some sort of treatment, whether it's surgery or radiation to the prostate, let's say, you want to restage for recurrence. You want to continue to observe patients, make sure that the cancer doesn't come back. Now, in prostate cancer, we're fortunate we have a pretty good biomarker with PSA, but there are other reasons to look for recurrence as well, and I'll talk about some of those as we get along. Some of these are newer findings in the field and newer directions for the field. But another reason is just for responsive therapy. If you happen to have more advanced disease and you can see it on the scan, are there ways we can follow imaging to determine how well someone is responding or not responding? But here are the real reasons why we image. The real reason is we want to find every bit of cancer we can to see if we might be able to improve cure rates or improve survival outcomes by either cutting it all out or doing radiation and trying to eradicate every last cell, because that's what you have to do to cure the cancer, or at least to cytoreduce or reduce those cells with the hope that you get the best outcomes down the road. Now, sometimes it's not possible to do that, and if you have good imaging modalities, on the flip side, if you find that the disease has spread, you might be able to use that imaging modality to say, okay, there are newer, good systemic therapies, ones that travel through and treat the whole body, whether it's IV or whether it's an oral pill. But these things have made a major impact, and sometimes we're better off to spare somebody the toxicities, the side effects of a surgery or radiation when we think it's probably not going to lead to benefit. So these are the real reasons why we do imaging. Now, PET imaging is a really interesting thing that's been used in many, many different cancers, not as much in prostate cancer until recently. And it has some real advantages. You know, if you do a CAT scan or an MRI imaging, those really just take pictures. They give you kind of a picture anatomic imaging. What do things look like? What a PET scan does is it kind of measures activity of the tumor, metabolic activity, molecular activity. So you can use different types of radio tracers and radio label them to image different things. It can be glucose metabolism, sugar metabolism. It can be things like lipid metabolism. There are protein synthesis. There are a lot of different things that you can image there. And the advantage is you get what's called quantitative information. Not just, okay, there's a spot right there, but how intense is that spot? Or how less intense is that spot after treatment? So you can actually get a real measurement there, whereas you can't just do that with anatomic imaging. Now, there are other biomarkers in this disease that I talked about, PSA, for instance, but that's a blood biomarker. It gives you kind of some general overview of what's going on with the disease. And you can biopsy tissue spots, too, and get information. And we've done a lot of research in those areas doing sequencing with biopsies to understand what genetic genes have been altered in your cancer. But that doesn't take into account heterogeneity, and that's the idea that not every cancer cell necessarily is created equal. And it's not just one person's cancer versus another person's cancer. It may be molecularly, genetically different. It could be even within your own body that these different cancer cells in different spots have different genetic alterations and makeup. And so one unique feature is you can get anatomic imaging combined with molecular imaging and get an idea looking at this heterogeneity. Sometimes we see this. You treat somebody with something and one lesion might be responding real well while another one isn't, and you can get that kind of information this way. So with PET imaging, I'll just tell you, for most cancers, when people just say PET imaging, they're talking about glucose uptake. FDG, okay, which is a type of radio tracer that's used that images really kind of glucose activity of the tumor. But prostate cancer is not so glucose avid, okay? It doesn't uptake it so well. So it's not a very good radio tracer for prostate cancer. Choline is one that images the lipid metabolism, the lipid membrane of the cells. And this is an imaging modality that has been studied in this disease, and it is much more sensitive. That means much more capable to pick up the cancer than, let's say, FDG or glucose imaging in prostate cancer. So this is just some data, retrospective data, that we see. This is the largest study, and as you can see from the images there, I mean, I'm not sure about the laser pointer, but, oh, here. I mean, you can see how it can uptake in different spots, lymph nodes, in the bone, in the prostate bed, in different areas there. But the key thing to recognize with choline imaging is that you probably need a PSA of around 1.5 to 2 before half the patients can pick up something. So if you're thinking about somebody who maybe had surgery or thinking about radiation to the pelvic region to try to eradicate every last cell, when you get up to that level, 1.5 to 2, it's getting kind of on the higher side of things already. So we want to have better imaging modalities. So we have fluciclovine. The other name for it is Aximin. It's also called FACBC. There's a lot of different names for this. The nice thing is this is FDA approved now. We have this here. It's a synthetic amino acid that's basically uptaken by transporters, preferentially in cancer cells, including prostate cancer. And it doesn't synthesize new proteins. It's not really incorporated that way. It hangs out, but it also has an advantage in the fact that, unlike a lot of these radio tracers that are excreted into the kidneys and into the bladder, that would be a problem, because if you're trying to look in the pelvic region and the lymph nodes, you're blocking everything there. This is not excreted that way into the kidney, so you can get a really good look into the pelvis there. So that's one nice advantage. And here's just some images here. As you can see here, you can see that this is compared to an older imaging study called Prostacin. And this I'll talk a little bit more about later, but it's not a very good imaging study. It's about what we call 50% sensitive, 50% specific. That means when you see something there, half the time it's cancer, half the time it's not. And when you don't see something there, half the time there's some cancer there. So it's just about useless, at least in my opinion. I remember when I was in training, one of my mentors, a patient brought this in and he said, okay, he goes, this is what I do with this now. And he put it in the garbage can. And I was like, wow. Okay, but really it's not that good. So fluciclovine is clearly much better. And so I mentioned choline. Well, this is better at detection. So you could probably detect in about 50% of the patients, you're going to detect things at a PSA level around 1 instead of 1.5 to 2 or so. With choline, here you're down around the level of 1, okay? So, and this is FDA approved now, and we're doing this very, very regularly, both at the university and at the Seattle Cancer Care Alliance. So one question that one has is, okay, how useful are these things? When you get these studies, do you actually make decisions based on them? As a doctor, how can you use these studies to make decisions? So here's a little bit of data. This is a FALCON called the FALCON Trial from the UK, and it was 85 patients. And what they looked at is they did this fluciclovine or Aximin PET imaging, and they looked whether, in response to the therapy, did the clinicians make a major change? Did they make a minor change or no change? And so what a major change is, well, I was going to operate on this, but now I see I'm not going to be able to get it all, so we're not going to operate now. We're going to do our newer systemic therapies. A minor change would be, well, I was going to irradiate this, but look, there's a little spot there too. I'm going to give a higher dose there now. That would be a minor change. And then, of course, there are no change. So about half the patients had uptake, And as you can see here, 61% of the men had a change in treatment. So it impacted the care that the patients got. 36% with a major change, 24% with some other change, which was more of a minor change, okay? So it clearly is impacting therapy to the point where in the United States they did their own study with 213 men, and they found detection rates, very similar data, about 57% of the patients. And what you see here is that if you look at major change, they found that, if you look at change, 59% of patients had some sort of change in therapy in response after they had this oxygen and PET imaging study. It was 78% of them being major changes. So I think it's very clear, if you get these, it will impact your treatment probably 2/3 of the time, up to 2/3 of the time, all right? The real question, however, is, was that an intelligent change? And that's what the field needs to answer, okay? And what many people are trying to do now, and what we're trying to do as well, because it's always important. And this is, the FDA has interesting standards that are different for therapies, you know, that we give for treatment of cancer than for imaging. The key thing that they want to see for imaging is that doctors use the imaging studies to make changes. But again, the greatest impact is when doctors use the imaging study to make intelligent changes that actually help people, right? So that's what we're getting at here. Now, PSMA, many of you may have heard of this. This is, again, a protein that's expressed on most patients with advanced metastatic prostate cancer, over 90%, okay? And you can see here by gallium-68 PSMA imaging, this images or binds to the external domain. You have antibodies that can bind to this. You have small molecules, all different things. Now, remember I told you about that imaging study that one of my old mentors threw in the garbage can, that processant? This binds into the internal domain of the protein, which is not always accessible, which may explain partially why it's not as good of an imaging study. But one unique thing about PSMA imaging is that it might be the most sensitive imaging modality. You're able to pick up the cancer in about half, 50% or more of patients with a PSA level down in the 0.5 range or less, okay? And so here's some nice pictures here with gallium-68 PSMA. This is choline. I told you about choline earlier, and you can look how vague it is. But here, you know, you can see really, really nice uptake here with an imaging modality with PSMA PET imaging. All right, and there's other ways to image PSMA. Here's just another compound that uses a different tracer. This is 18F-PYL imaging, and in this study, they're trying to get this FDA approved as well. This study here, what they're doing is they're taking patients who either haven't had surgery yet and are going to get surgery to the prostate and the pelvic lymph nodes, or who already have had treatment of their prostate and their PSA has gone up and their disease has recurred. And they're picking patients where they're going to get tissue from, either surgically or through a biopsy, and they're doing the imaging modality, and then they're determining how sensitive and how specific it is. And again, what that means is when you see something there, is it really cancer or is it a false positive? It's not really cancer. When you don't see something there, is there cancer there? That's more specificity, okay? So this may get FDA approved, I mean, who knows, maybe 2.5, 3 years from now. But that's really the goal of this study, is when we see something, are we sure it's cancer or not? Now I want to move on to another part of the talk, which is focused more on what I was saying earlier. When you see something and you change your treatment and you're doing something in response to the imaging, are you doing it intelligently or not? And the field is moving a little bit towards, when you find something, if it's not widespread and it's maybe 1 or 2 or 3 spots, maybe going after it, okay? Let's say you've had your prostate out already, your PSA's gone back up, you get an imaging modality and you find it in one lymph node. Well, maybe we should take that lymph node out or do radiation. We don't know yet, but this is actively under study. And here's just some data from a well-recognized publication that shows that the theory behind this is that cancer doesn't start from one spot and spread. It starts from one spot and can spread to another spot, and that other spot can now seed other places. And that's the point of all these arrows here, is they sequenced the tumors and they looked at the genetic alterations, and they were able to prove that different spots were serving as other sites to seed. That leads some credence to the idea that even if you don't cure patients by eradicating 1 or 2 spots that you find on the scan, maybe you can add some benefit by preventing additional seeding of the tumor, okay? We don't know the clinical results yet, but that's the theory behind it. Now, there have been many small studies in many cancers, and in prostate cancer, I still think this is probably the best study, which is the STOMP trial. It was a randomized trial done with choline PET, and again, I told you I think we have better imaging modalities now than choline, but what they wanted to do is they found 3 or fewer metastatic sites, okay, in somebody who had recurrent prostate cancer by PSA. They were then randomized, which means half the patients got a certain treatment and half didn't, and you didn't get to pick. The doctor didn't get to pick. A computer randomly generated that. Half got randomized to trying to go after those spots with surgery or radiation, and half got randomized to observing them. And the primary endpoint was an interesting one. It was androgen deprivation therapy or hormone-free survival. And the reason is we know hormone therapy has side effects, and there are a lot of patients who are hoping to delay hormone therapy as long as possible. And so this may be a very meaningful side effect, I mean, not side effect, but meaningful endpoint if you're delaying the time to need these sort of hormonal therapies, okay? And this is what they showed, is that if you had something that lit up on the PET scan and they went after it with surgery or radiation and they were allowed to go after it multiple times, I think almost a third of the patients had retreatment, that what they found was just the amount of time it took till you needed to be on hormonal therapies was longer for those that had metastasis-directed therapy, as they called it, or MDT, where they went after the spots with surgery or radiation versus those where you didn't. So those patients had a delay in the time until they needed hormonal therapy. Now, these are waterfall plots where every single one of these lines here represents a patient and their PSA level. Did it go down or did it go up? And you can see here, those that had metastasis-directed therapy in blue, or green, I'm a little bit colorblind, but bluish green, that had many more patients with their PSAs going down, of course, since they were ablating some of these metastases than in the surveillance arm. I do find it interesting that this many people in the surveillance arm had their PSAs dropped. It's not really clear why that was. But here's one thing that's interesting as well, is they looked at PSA, biochemical recurrence-free survival. That means how long you had your PSA low before it started to come back up again. And that was significant for metastasis-directed therapy as well. So I think this study was able to show that if you do this, you're able to delay the time until you start somebody on hormonal therapies. Now, we are doing some of these studies here now as well, and this study is not started yet, but it will hopefully kick off in the next 3 months or so. As I told you, we're doing this oximet PET, and we have a nice registry where we're capturing patient information. We're doing it for patients that have a clinical indication. We're capturing their information. But this study is going to include intervention. So we're going to do this oximet PET. If we find it in 3 or fewer regions, we're going to be doing combinations, hormonal therapies, a newer agent called abiraterone that inhibits testosterone even lower, and then maybe going after lymph nodes with surgery or radiation. And that, what we're looking for is how long we can get patients, how many patients we can get to an undetectable PSA and keep them there, and we're going to be looking at that 2 years out as a primary endpoint. We have some data that we've established from our center that shows that that endpoint seems to correlate with long-term survival outcomes as well. All right, but the direction this field is moving, okay, is not just doing these imaging studies, finding the cancer and going after it and proving that that makes an impact, but it's using these targets as a targeting mechanism to bring new drugs there, like radio tracers there. So this is just an example of somebody who had a PET imaging study, and they created this radio tracer, which was lutetium, and it's attached to a small molecule that goes to PSMA, and you can see the dramatic changes before and after treatment and how many patients had significant drops in their PSA. So it's called a theranostic, where you're not only imaging it with an agent, but now you're attaching something that has radioactive activity that's being brought to the cancer cell that can attack that. Here is the randomized phase 3 study that might get this FDA approved in the future with an agent like lutetium PSMA-617. Right now, it's basically being studied in patients who have had prior chemotherapy with metastatic disease that's hormone resistant. And we'll see if this gets FDA approved, but I think it's quite promising. There are other types of these agents. There's one that's another small molecule, 1095, that brings another type of radioactive agent, I-131, that is being used in thyroid cancer, and the early data looks very good too with most patients with a PSA decline. You can see the pre-therapy versus post-therapy PET imaging studies look quite nice. So I've worked with the company to help design this study here, where we're going to be taking patients that would be getting enzalutamide, which is a blocker of the hormone receptor, androgen receptor that sits on the cancer cell, versus enzalutamide plus this radiotracer therapy, or radioligand therapy is the other term for it. All right? So just to wrap up, we're doing a lot of exciting next generation PET imaging. That's kind of the term we're calling it now, next generation imaging, with these novel radiotracers like Fluciclovine, like PSMA. We're going to be bringing PSMA here into the near future. We're starting to do aggressive trials using these PET imaging modalities to find the cancer earlier and then go after it with surgery or radiation. But the real future might be using these types of tracers to bring drugs to the area. And the IPCR is definitely dedicated to bring these imaging modalities and these treatments here. Thank you very much.
Thanks, Evan. So our final speaker is Dr. Bruce Montgomery, who's a medical oncologist